Visible?
Yes, sir.
So the anesthetic consideration for neonatal surgical emergency, that is our question. Okay. So first thing, you can define what is a neonate. Any baby up to 44 weeks of post-gestational age. Whether they are born at 37 weeks, then you have to wait for another 7 weeks to make them 44 weeks. If they are born at 40 full term, then up to first 28 days, they are called neonates. So 44 weeks of post-gestational age is a baby, which is considered as a neonate. And issues of concern in the neonatal anesthesia are first and foremost is thermoregulation, glucose management, third is positioning, fourth is intubation and airway management, fifth is respiratory system and metabolic oxygen requirement. And sixth is the cardiovascular system differences. Circulating blood volume and blood loss is a very important consideration. And pharmacology and drug metabolism. So this is how you have to first identify all the problems. So 1, 2, 3, 4, 5, 6, 7, and 8 problems. Thermoregulation, 2 glucose management, 3 positioning, 4 intubation and airway management, 5 respiratory system and metabolic oxygen requirements, 6 cardiovascular system, 7 blood volume and blood volume loss, 8 is pharmacology and drug metabolism. Now coming to thermoregulation in neonates, infants have less brown fat, therefore less thermogenesis, and neonates are so small that proportionately a more substantial percentage of skin gets exposed in the operative field during most surgeries, and their head size is larger compared to the body and more body surface area is exposed. So heat loss is much more faster and more in quantity. And when you give general anesthesia, the thermoregulatory function at the thalamic level is also interfered with. This happens to everybody, but in neonates, it is a very significant factor. And they depend on non-shivering thermogenesis because they don't have adequate muscle mass to cause shivering thermogenesis. So it is common for the temperature to drop by 1 or 2 degrees Celsius in the first hour of anesthesia in the neonate. So we must first give all our attention to maintain the normothermia in the neonate. So what are the remedial measures you have to do to prevent this hypothermia? You keep the ambient temperature to 78 to 80 degrees Fahrenheit. That is, OT temperature should always be at a higher level when you anesthetize and operate on an infant or a neonate rather. It is also common to use warmers, forced air warmers and transformers and all those things. And hat should be used to prevent heat loss from the head. You can cover the baby's head with a hat. You can use a warm humidifier even to the ventilatory circuit, and all fluids and other things given intravenously should be warmed, and all blood products should be transfused with a warmer. And keep the baby covered as much as possible, even during transport from and to from the OT. And there are instruments called isolates, which are kept, plugged and kept ready in preparation for transport. So this is a what is called an isolate. You can see a plastic cover completely. Inside is the neonate, and it has got openings which are having a door which can seal the opening completely. Whenever you want to handle the baby, instead of exposing the entire baby, you can just put your hands through these folds and then attend to the baby and then keep these folds closed again. So this enclosed space is always kept at the body temperature of 37 to 38 degrees centigrade. This is what is called a isolate. And second thing is the glucose management. So neonates have decreased glycogen stores and are prone to hypoglycemia. even if their NPO status is very short. That is because of the two reasons I told you earlier. One is the lack of glycogen storage and the inability to prepare glucose from other substrates, what is called the gluconeogenesis. So the common IV fluid of choice in the neonate, not in the infant. In the neonate, it is 10% dextrose in water, and also it should ideally contain 0.2% sodium chloride, because as I said earlier, the proximal convoluted tubules are not good enough to retain the sodium. So they are obligatory sodium losers. So it is better to give them a very small concentration, not the 0.9% sodium chloride, but 0.2% sodium chloride can be given. So this should be the combination of IV fluid, preferably for a neonate. Then coming to the positioning, neonates have a very thin skin and relatively little fat stores, thus making positioning and rechecking of position very important. So the skull especially is very flexible and soft, because that is the way it comes through the birth canal. So it can adapt and then slip out, especially in normal vaginal deliveries. This soft nature of the skull only makes it easily come out through the normal vaginal route. And that softness continues during the first 28 days, that is the first 4 weeks after birth, or up to 44 weeks, the softness is there. So you have to protect the skull and the head very closely. So they usually use what is called a gel horseshoe or other headrest, which is there. So this is how it will look like, a soft bean-like thing over which your head can be supported. Then coming to the intubation and airway management, when intubating a neonate, one should know that the anatomy thoroughly. And we saw in the earlier class how is the difference, what is the difference between the anatomy of a airway of a neonate to older children and adults. So it has a larger head compared to the body, larger tongue, floppy epiglottis, and more cephaloid position of the larynx. And it is easier to intubate the neonate in the neutral or slightly flexed position owing to these anatomical considerations. So do not use the morning air sniffing position or the position that you adopt for an adult, like flexion at the cervical spine and the extension at the atlant occipital joint. That should not be the way you do it in a neonate. So you have to keep it in the neutral or slightly flexed position. So for a proper oxygenation and pre-anesthetic pre-oxygenation, this is what you can do. You can usually give a roller under the shoulders, and then because the head is large enough, never give any support at the occiput level here. Okay, because the head is big enough, that will make it supported well on the mattress. So you have to just give a small roll under the shoulders, and then keep these two uh, lines parallel to each other. That is, the anterior neck space should be wide open. So in order to do that, just hold the jaw at the angle of the mandible, and then give a slight pressure on the face mask over the nose and mouth, and gently lifting of the jaw. That is what you have to do. Then it will open the space. So remember this picture well, how to oxygenate a neonate. And when you do the intubation, invariably, what type of laryngoscope will you use? Sonakshi, when you want to intubate a neonate?
Sir, a straight plate
Very
laryngoscope.
good. A straight blade you have to use because you can include the epiglottis.
Yes, sir.
So when you use that, if you don't have any helping person, then you must always learn to hold the handle of the laryngoscope with your thumb and index finger and middle finger, and use your little finger to press on the trachea to
Yes.
expose the vocal cords, and you can see the tube is going in here. Okay? So this is how most of the Pediatric anesthetists who are especially trained in neonatal intubation, they will be always doing this with a very, very gentle way on their own without any need for external assistance. You can use your own little finger to press on the cricoid level and visualize the glottis and intubate. But if somebody is there to help you, then that helping person, what they should do is they should use their both the hands. One hand should stabilize the trachea at the cricoid level, and their other fingers should pull the jaw angle of the mouth away like this to open the mouth more comfortably. Okay? So these are the two techniques. The person who is going to help you should always do like this for easy intubation of a neonate. So the operator can just lift the tongue and epiglottis together like this in this direction, and the person assisting the main anesthetist will have to do these two maneuvers: slight compression at the cricoid level and pulling the or opening the angle of the mouth away, which will give a wonderful, beautiful view for the operator to insert the endotracheal tube very easily. So these pictures you can remember for practical purpose sake if you plan to take up neonatal anesthesia in the future. And there is a rule created by one token, created what is called 789 rule to, because the depth, as you rightly said, the trachea of the neonate is very short, and so if you inadvertently pass the tube longer in the trachea, it will invariably go into one of the bronchi and will result in one lung ventilation. So in order to avoid that, you must know this rule to remember what is the actual depth you have to introduce beforehand, so that you will stop short at that level without pushing the tube further down. So what is that you have to do is, if the child is 1 kg in weight, and because neonate, at birth, normal birth weight is supposed to be 2.5 to 3 kgs, but sometimes babies can be having a low birth weight. So if the baby is just 1 kg at the time of birth, if the weight is only 1 kg, you have to stop short at 7 centimeters at the gum level, because the teeth are not there. You take the gum as the anatomical point. And if it is 2 kg, you can go up to 8 centimeters. And if it is 3 kg, 9 centimeters. So another method of remembering this is 6 centimeter plus the weight of the child in kg. Supposing a baby is chubby baby born at birth itself, it is 3.5 kg. You can go up to 9.5 centimeters, 6 plus 3.5. Okay. Very rarely, children can be also 4 kgs in weight. Extremely, what is called macrosomia children, sometimes they may be 4 kgs in weight. Then you can go up to 10. So this is the rule that you have to follow to avoid endobronchial intubation. This is one of the important things you have to know as a neonatal anesthesiologist. Then coming to the respiratory system and metabolic oxygen requirements, neonates desaturate quickly and take a while to recover once desaturation occurs. What are the reasons for that? Why neonates? You already mentioned in your answer. Can you recall that, Sonakshi? Why they desaturate faster? It is
Sir,
there in your answer. I just want to know whether you have understood the point and then written the answer, or just guided by the seniors you have prepared it. Your
sir, the
presentation
cardiac,
was beautiful. You mentioned this point in your answer, why they are likely to desaturate and become hypoxic much more faster. Because what is their FRC? Is it normal like an older
no,
child?
sir, no, sir, yes, sir, decreased
They have a low FRC. Can
Yes, sir.
you name a few other conditions where people have low FRC, functional residual capacity? This is a very common Viva question they will ask you in the exam. What are the other conditions where FRC can be low? One is a neonate.
Sir, in neonates,
Uh, do pregnant women have a low FRC?
yes, sir.
Why?
Sir, the diaphragm, because of the uterus, distended uterus.
Excellent, excellent, very good. Because the diaphragm is splinted and pushed upwards. Very good.
Yes,
Okay. Obese people, do they have a low FRC?
yes, sir.
Yes, the same reason. Okay.
Yes,
And so all these things you have to recall and remember. So, and why it is taking time to recover? The reason is the closing pressure of neonatal airway is very low, and it occurs very quickly with the loss of ventilation. And it will take time for those alveoli to open and participate in the ventilation. Okay? So, in addition to that, their FRC is low. And for remembering the other conditions which which have a low FRC, I always tell this mnemonic to students and goes P for pregnancy, A for ascites, N for neonates, G for general anesthesia, O for obesity, and S for surgery in the upper abdomen. So all these 6 conditions cause low FRC, which can result in faster desaturation. So in addition to neonatal oxygen consumption is also very high. They have a very high oxygen demand. So they have 6 ml per kg compared to only 50% in the average adult. So the 3 reasons why they become desaturated and take time to recover are low FRC, high oxygen consumption, and delayed opening up of the alveoli because of the lower airway collapse pressures. And if you allow them to breathe spontaneously during any procedure, they will become fatigued and the work of breathing will be more in them because they have less what is called type 1 or slow oxidative muscle fibers in their diaphragm. So it is advisable to go for controlled ventilation rather than spontaneous ventilation as far as possible for any surgery. And the ribs of the neonates, they lack what is called the bucket handle movement that happens in the adult. So this will result in less negative inspiratory pressure creation, and this will also cause or add to the increased work of breathing to cause fatigue in the baby. So these are all the common respiratory system and metabolic oxygen demand points you have to remember and write in your exam paper for the reason why neonatal anesthesia is more challenging. Coming to the cardiovascular system, the neonatal myocardium is less compliant than adult myocardium, so making cardiac output heart rate dependent. This is a very important point you have to write in your examination, that their cardiac output is always rate dependent. And to add to the misery, they always go for bradycardia. Whenever there is a hypoxia, hypovolemia, hypotension, unless an adult, unlike an adult, they can't cause tachycardia to compensate for that. They go for bradycardia. What is the reason? Sonakshi, why they develop bradycardia more commonly than tachycardia?
so the nervous system is not.
The parasympathetic is developed well at birth, but sympathetic system is not well developed. It
Yes,
matures only at the age of 3 years. So until the baby is 3 years old, it will have a dominant parasympathetic activity in the heart. So any stress will lead only to bradycardia rather than tachycardia in the newborn babies and infants also. So you have to keep a watch on the cardiac output. And neonatal vasoconstriction is also less responsible to hemorrhage, with 10% reduction in blood volume and 30% in mean arterial pressure. So they poorly tolerate blood loss. So what you mentioned as replacing with 1:1 and 1:3 crystalloids and colloids does not apply to the neonates. It can apply to infants and older children, but in neonates you have to remember that it is always blood for blood. No replacement with crystalloids or colloids.
Okay.
And they have less calcium stores in the endoplasmic reticulum of their myocytes, so they depend more on exogenous calcium for the myocardial contractility. Okay? And volatile anesthetic agents, they can cause the blockade of the calcium channels to cause more cardiac depression in neonates compared to the older children. So these are all the points you have to remember with regard to the cardiovascular system. And to that you have to add how that switch over from fetal to adult circulation back to this can occur. I'll show that again later. Neonates have a high blood volume. They have almost 90 ml per kg, that's their circulating volume, compared to the 60 ml per kg for an adult. And you must always have a calculation of the maximum allowable blood loss that you can admit in a child neonate when it comes for surgery. So this formula has to be written with regard to the estimated blood volume, allowable blood loss that can be accepted. That is calculated by estimated blood volume of the neonate multiplied by initial hematocrit minus the accepted or final hematocrit divided by the initial hematocrit. Some books say you can take the average of the initial and final hematocrit for a denominator of this formula. So estimated blood volume is calculated based on the body weight and the average blood volume. So if it is a neonate weighing 2 kgs, 2 into 90, 180 ml will be the estimated blood volume. Then initial hemoglobin, H1, final hemoglobin, and so most neonates can lose only 50 to 75 ml of blood before considering a transfusion of packed red cells, as this is usually 20% of their circulating blood volume. And so you have to be very watchful that they can become hypovolemic very fast. In coming to the pharmacology and drug metabolism, renal and liver maturation happens around 6 months of age, and so all drugs to be used with caution. And you have to have a proper plan and keep all necessary special equipment in the OT, and calculate the drugs and keep them loaded on a weight base, and label them so that you don't have a mix-up, and keep all measures to keep the baby warm. And I have always dextrose ready for correcting the hypoglycemia. And the positioning and plan for intubation, calculated doses of allowable blood loss, all these things, it is better written on a board in the OT so that anybody can see and can follow the rules. And clear communication between anesthetist and surgical team is very important to guide the neonatal anesthetic plan. Now, after all these points you have learned, then you go for the commonly encountered neonatal surgical emergencies, which can be classified into emergent surgical things and urgent surgical things. Under the emergent, you get the necrotizing enterocolitis or abdominal wall defects, and the urgent, you have to include meningomyelocele also in the neonatal emergency surgery, because it will have a thin covering, and the chances of rupture, infection, or permanent nerve damage are very high. So they have also to be taken up as early as possible for repair. Tracheoesophageal fistula and congenital diaphragmatic hernia, they are all considered as urgent, not emergent. So emergent is you try to do within the first 1 or 2 days of after birth. Whereas urgent, you can take even 3 or 4 days wait and optimize the baby and do the surgery. Now coming to your mode of presentation, preoperative assessment optimization, you take a general history with regard to the pregnancy of the mother, whether it was the antenatal period, was it normal or associated with any PAH or other complications. Was the delivery by normal vaginal delivery or cesarean delivery? What was the birth weight of the baby? Was it born at full term or prematurely? What was the Apgar score? And what is the gestational weight? All these things have a bearing on the prognosis. And then, if the child is born with a diagnosis made in the antenatal period itself, nowadays with the ultrasonogram being done in the mother to find any anomalies, majority of the congenital anomalies are detected even in the antenatal period. So if that is known, the neonatal team will be ready and immediately take remedial actions as soon as the baby is born. Even though surgery is not carried out, like procedures like intubation to keep the baby, prevent hypoxia, and other corrections as much as possible are done. So baby may be near the NICU with an intubated condition and then coming to the OT with the tube in situ. So all these things you have to note down in your history and keep a watch on the blood loss because that is a very important thing again and again. And blood should be available inside the OT. Whenever you take up any major laparotomy in a neonate, you cannot order and wait for the blood. It has to be available in the OT all the time. And coming to the airway history and examination, history of airway problems with the previously difficult mask ventilation or laryngoscopy, all these things, if already been tried, it should be mentioned, or you have to make a thorough examination and find out. Sometimes, as I told you earlier, the child would have been intubated as soon as it was born and then brought to the OT in an intubated condition. So check the level and make sure it is not migrated endobronchially or moved out. And any obvious deformities like Peary-Robin syndrome, which are going to give problem for intubation, it should also be noted for. Now, what is the respiratory history and examination? Respiratory condition that will impact the anesthetic will be the infant respiratory distress syndrome. So some babies, especially those born before term, premature babies, they will lack the surfactant and they may be born with an infant respiratory distress syndrome, for which it may be initially treated. In such babies, there may be an associated congenital anomaly or a surgical condition which may require a surgery. So you have to make sure that there is no history like infant respiratory distress syndrome present, or if again the prematurity may also lead to what is called post-operative apnea. So children born before 36 weeks, they are also prone for what is called apnea of prematurity, which can happen up to 60 weeks in the post-gestational age. So they may be liable for that. So the babies have to be watched properly. Coming to the cardiovascular history, the focus should be on volume status by noting the heart rate, arterial pressure, and capillary refill, core and peripheral temperature, and urine output. So these are the 5 parameters by which you can assess the volume status: heart rate, arterial pressure, capillary refill, difference between core and peripheral temperature, and urine output. And metabolic acidosis may indicate a continued poor perfusion, but also may indicate a dead or critically ischemic gut in the cases of necrotic enterocolitis. And clarify progress if there is any associated congenital heart disease present in that has to be mentioned, whether it is what is the nature of the heart disease and how severe it is, everything should be. And venous access should be noted. Then coming to the investigations, you have to have an initial value of hemoglobin so that you can calculate the allowable blood loss. You must know the coagulation status. Majority of them may be having a mild coagulation defect because of vitamin K poor absorption. And you must cross match and keep the blood ready. Electrolyte and blood gases should be done. And echo and chest X-ray is important to find out any cardiac condition. And coming to the perioperative management, preparation of the patient, you have to adequately correct any volume deficit and blood loss. And then coming to the induction of anesthesia, mainly it is done by IV or by inhalational or a combination of both. So it is not always necessary that you should do only one type of induction. So based on the hemodynamic stability, it can be by IV drug induction, or it can be by a inhalation or by a combination of both. So coming to airway management and ventilation, all that points that we have to noted earlier should be kept in mind. And ventilation is usually done by paralyzing the patient and controlled ventilation. And if you are going to use a ventilator, it is always preferable to use pressure control mode rather than volume control mode, which point Sonakshi mentioned. And thinking of analgesia and postoperative care, a multimodal approach to analgesia is always safer. So these are all some of the general points. Now coming to the specific conditions, as you mentioned, omphalocele is a midline defect associated with other anomalies. So it can be the bowel exposed conditions are two common conditions, gastroschisis and ampulocele. So ampulocele, it almost comes out like an umbilical hernia through the umbilical defect. Whereas gastroschisis, it always is to the right of the umbilical attachment. It is not through the umbilicus. And because in both the conditions, the bowel is a small bowel and some part of stomach, colon, all these things are exposed, this may require early correction. So it is just like repairing a hernia, putting back all the bowel back into the abdominal cavity and closing that. But that will result in a tense abdomen, flinting the diaphragm, which may cause difficulty in breathing. So it may be done in a single stage, depending upon the bowel content that is excluded out, or it may be done in a stage procedure. Initially, some part is resistant, then later on, repeat surgeries are common in this condition. And you have to decide whether you have to discuss with the surgeon whether it is going to be a single stage procedure or a multiple stage procedure. Based on that, if it is a single stage procedure, it is better to electively ventilate these babies postoperatively so that there is no respiratory distress because of the splinting. And that will require adequate pain relief so that the patient can comfortably be ventilated. Then coming to the lesser urgent condition is pyloric stenosis. It usually occurs in the second to sixth week of life, and neonates have a projectile non-bilious vomiting, resultant hypochloremic. Before surgery, measurement of electrolyte and correction of hypovolemia and alkalosis can be done with the administration of 10 to 20 ml of. So I'm just mentioning the specific things that you have to write. You don't have to write all the details about each and every condition. So what are all the just important points that is specific to that particular condition only you have to write. Then coming to the necrotizing enterocolitis and intestinal obstruction, and then of course the peculiarity about necrotizing enterocolitis is this is a condition where you are not supposed to administer epidural or neuraxial blockade because of the infection chances. The epidural infection abscess formation is more common. So the only condition where an epidural analgesia is contraindicated is necrotizing enterocolitis and but intestinal obstruction, of course, you can give it if there is no bowel perforation and peritonitis. but definitely in the necrotizing enterocolitis, they do not advocate epidural anesthesia. Coming to congenital diaphragmatic hernia, the peculiarity about this condition is it is very much diagnosed antenatally by doing the ultrasound in the mother. And if it happens at the early stage of organogenesis, like the age of 3 months or 4 months of amenorrhea itself, then the uh, abdominal contents occupying that part of the thoracic cavity does not allow the lung to grow. So there is a very hypoplastic lung, and that will result in severe hypoxemia when the baby is born. And so these are the few points about necrotizing enterocolitis, primarily seen in premature and low birth weight children, and it manifests as obstruction in second to sixth week of life, can occur as a result of bowel ischemia and hypotension due to poor cardiac output state and infection. And these two emergencies, that is necrotizing enterocolitis and intestinal obstruction, both have similar clinical picture with abdominal distension, hypotension, coagulation failure, dehydration, etc. And neonates are really critically ill, so they will be treated in the neonatal care, and invariably they come to the OT with a EP tube and inotropes, and very judicious fluid management is required for NAC. You have to give 70 ml per kg, and nasogastric tube insertion is essential for gastric decompression. And the induction agent of choice here is ketamine rather than your regular propofol or other IV injection or inhalation agent, because they are invariably hemodynamically unstable. So the induction agent of choice is ketamine, which can preserve the hemodynamic status as well as a good analgesic also. And rapid sequence induction is always necessary. And if they are already intubated, all these questions of parasite do not come. And don't use nitrous oxide in these cases because it will cause bowel distension. And epidural analgesia is contraindicated due to sepsis and coagulopathy in NAC cases. But in intestinal obstruction without peritonitis, epidural analgesia may help in postoperative ventilation. And always an intra-arterial catheter is advisable for this case because these children will be hypotensive and may require frequent laboratory assessment also. And post-op management may require meticulous fluid management, inotropic and ventilator support, and antibiotics. Now coming to the congenital diaphragmatic hernia, herniation of abdominal viscera into the thoracic cavity leads to pulmonary hypoplasia if it happens early in the pregnancy during organogenesis. But sometimes congenital diaphragmatic hernia happens late also after the organogenesis is complete. In that condition, the lung development would have been achieved almost completely, and then only a small portion of the stomach and intestines they herniate into the thoracic cavity. Such babies do very well because their lungs are well developed, they don't suffer from hypoxemia. Whereas if the diaphragmatic hernia happens in the early stages of organogenesis, then these children are born with severe hypoxemia because of lack of the lung on one side. So they are initially treated with high frequency ventilation and nitric oxide inhalation and vasodilator. If they don't respond to these things, then they are put on ECMO as a last method to salvage them. So when the factors which predict a poor prognosis in congenital diaphragmatic hernia is when the oxygen saturation is less than 80 or carbon dioxide more than 40. After all the therapy, it indicates a very poor prognosis. And the patients have to be stabilized before surgery because they will also have pulmonary hypertension because of the reduction in the lung parenchyma stage. And oro or nasogastric tube is inserted to prevent further distension of the abdominal organs which are coming to the thorax. And if they come with an ECMO support, then you can give isoflurane through the ECMO and induce anesthesia. This is one advantage of that. And all the drugs you want to give also can be directly given through the ECMO circuit. But because ECMO requires heparinization, bleeding will be more. So you have to watch out for the blood loss and replace the blood loss. And with regard to the meningomyelocele, there are two locations where meningomyelocele occur. One is the cervical level, another is the lumbar level. So this cervical level meningomyelocele is more of a challenge to intubation, whereas lumbar is more of a challenge in positioning for intubation. So you have to use a special donut ring to support that meningocele area so that it doesn't get compressed and rupture. Whereas for the cervical meningocele, you have to position the baby in a way so that it doesn't get compressed and cause any problem. So like this, this is not a fully completed answer. Just to give you a clue and idea how to answer this question, and like that you can just mention a few points specific to each and every condition so that the answer can be completed. Okay.